And when I had this echocardiogram done, there were some complications with my heart, and the reading was sent to another cardiologist to read it, and that was a 2 week process between that. And then after that, I was somewhere in Kentucky on assignment, about to go do an interview, and I was told that I need to rush back home to my cardiologist. And my cardiologist admitted me to the hospital. Next thing you know, I'm having open heart surgery, and we are here today to talk to an amazing doctor. And this doctor that we're going to talk to, where he's going to talk to us about some cardiac deals and some issues and some things that are going on, and how medical research and things that he's already done, are providing a healthy future for people like me and for other people that have issues with their heart. So before I go any further, I would like to pass it along to Dr. Peter. Don't let me chop your last name up. I'm going to say Kowally.
Kowey.
Kowey. Okay, Dr. Kowey. So, Dr. Kowey, let me pass forward to you. Please tell everybody about your specialty and why you're here today, if you don't mind.
No, first of all, I'm really happy that you're making a good recovery. Open heart surgery is can be difficult business. It sounds like you're going to do just fine. So that's good for all the fans out there. Um, I'm a cardiologist, but my particular area of interest within cardiology is cardiac rhythm problems. So you probably have seen on a lot of television ads in the last couple of years about people who have heart rhythm problems, like atrial fibrillation, for example. And that's a subspecialty, a subspecialty within cardiology and my own area of particular interest. And I've been doing this for, as a physician as well as a researcher and teacher for over 40 years,
Wow.
and enjoying it quite a bit. But that's the area of my of
All right.
expertise.
Now, let me ask you this. What drove you to do this? Like, because you could have done anything else with the heart. You could have been the guy that works in the heart cath. You could have went anywhere you wanted with the heart. What made you want to go into this specific area?
Well, it started with an interest uh, in physiology and cardiac physiology. I thought that the heart is obviously a very complex organ, but it's driven by an electrical system. And uh, back when I was coming out of my residency in medicine and making a decision about cardiology, this subspecialty of rhythm abnormalities was just really beginning. And so it was really the frontier of trying to learn about the electrical system of the heart. People were just beginning to put catheters inside the heart and make electrical measurements, just beginning to develop things like pacemakers and defibrillators that we now take for granted in the practice. But it was really a very early time. I was really very taken by the idea that people who had a very serious and life-threatening cardiac arrhythmia, uh, that I could potentially fix that problem and have them literally live a lot longer than they would have without these interventions that we were developing. So it was a major impact area, as well as being a very interesting area from the scientific point of view.
Okay, I like that. Now, my next question is, so you get involved and you get into the specialty and you're on the forefront of it. You're actually seeing like an actual creation. It's not like you're just seeing like someone's already invented something and you're actually in the forefront. How does it make you feel now looking back? Let's take 20 years off. 20 years in pioneering some of the techniques and some of the research that's gone along with everything that's gone on here. How does that make you feel?
Well, it's very gratifying to see the ripple effect of what you do. That's one of the reasons, people ask me about why do you want to do research and why do you want to do clinical trials and get involved with new devices and new drugs, and it's a ripple effect. So through the things that I've done through the development of drugs and devices, I've impacted the care of literally millions of people around the world because the things that we develop, for example, our center when I was in 1982 was the third center in the world to implant the cardioverter-defibrillator, the defibrillator device that is now used in literally hundreds of thousands of people around the world. We put the third one in.
Whoa.
The inventor of the device, a guy named Murawski, was standing next to me when we implanted it in a patient at my hospital. So obviously that device now has had a major life-saving impact. I was also one of the people who developed anti-arrhythmic drugs. There are some drugs that are currently used very widely for the treatment of very serious cardiac rhythm abnormalities that came out of our laboratory. So I really feel like uh, rather than treating one patient at a time, as a physician, I've also had the opportunity to treat thousands of people indirectly because of what we've been able to develop.
Okay. Now, in your opinion, what is the most significant advancement you have seen in this field? Like, if you want to just go full circle, what are the advancements that you've seen, like once again, how we did like the 10, 15, 20-year deal, like 20 years ago till now, what is the most significant advancement you have seen thus far?
It's that's a very difficult question because it is amazing how we've advanced. I mean, the development of drugs and devices in my particular area has been explosive. I mean, as I mentioned, the defibrillator, which obviously had a major impact in pacemakers, we've now come up with techniques to ablate arrhythmias. So you've heard that term. It means that we can put catheters inside the heart and deliver energy through the catheters to actually cauterize tissue where bad rhythms are coming from. Atrial fibrillation is as an example of our ability to ablate arrhythmias. We've developed new blood thinners. And blood thinners are very important for the development of strokes and people who have a variety of forms of cardiac arrhythmias like atrial fibrillation. We now have much better drugs for that particular use. We have lots of really good diagnostic techniques now. You see on television advertisements for recording your heart rhythm and detecting whether or not you have a heart rhythm disorder. All of that technology is developed within the last 20 years or so. And so it's been very gratifying because it's not just been one or two, it's been a whole array of things that have come forward to really improve the care of patients.
Okay. Now, since you're a doctor, I do need to ask you this. Can you differentiate for us clinical practice and the actual medical research? Like how that works out for you? Because when we're talking here and I say clinical practice and medical research, someone may think that's the same.
Mhm.
Could I get you to clarify that for the audience?
Of course.
Thank you.
They're very intertwined. Okay, so all of us who practice as cardiologists are trained to take care of patients in clinical practice. So we all have that skill set of being able to examine patients and do ultrasounds and to do cardiac catheterizations and a bunch of procedures. I mean, all that stuff is clinical practice. Medical research is much smaller group of clinicians have decided that they want to explore new ways of doing things, so better understanding and better techniques for what we do. And so we spend time, at least part of our time, in addition to clinical practice, investigating new drugs and devices or trying to understand some of the physiology or the pathology of the hearts of the people that have diseases so that we can come up with new techniques and new methods and improve things for the care of patients. So research basically is trying to push that cutting edge further out and come up with new ideas. Not everybody in clinical practice does medical research. As I said, it's a relatively small percentage of people who choose to do both, and at the same time also do some teaching because that also goes along with what we do in medical practice as well as research.
Okay, okay. Now, let's get into a little bit about your college. And the reason I want to get into to your to like your university and all this other stuff, um, you're a professor of medicine. And where are you a professor of medicine at?
Thomas Jefferson University in
Ooh,
Philadelphia.
okay, okay. So you're a Philly guy. Now, are you
I'm a
for,
Philly
now?
guy.
Now here's the thing, and this is what I get with people in Philly. Everybody's let me see, area code up here, 215, right?
Yes.
All right, now, are you really from Philly or are you from Upper Darby or Villanova? And I always ask people because I've got friends that live out there, and I had a buddy, he told me he was from Philadelphia. I went to go visit him, and next thing you know, he lived in Villanova.
No, I don't reside within the city limits, but I went to school within the city limits. I went to Penn, which is obviously right in
Okay,
the middle
yes,
of
yes,
Philly.
yes.
And Jefferson is in Philly, so my medical school is in Philadelphia, but I live in the suburbs. I live not far from Villanova, in a place called Bryn Mawr, which is where I am now. It's a really interesting question because people who live in the surrounding suburbs always identify themselves as being from Philly, even though they're not purebred.
Okay, okay. Because I get that a lot. And then where's the other city? Is it Chester that's nearby?
Yes,
Yeah, people
Chester's
say they're
fine.
from Philadelphia and then they're from Chester.
Yeah,
And
it's
I
not
always get
far.
that. Now, getting back into to your career here, um, what is a big challenge that we are facing right now in your cardiology specialty?
Well, it's the same problems that we have across specialties. Obviously, there's lots of things that we still need to solve within cardiology, better ways of doing things, better treatments for patients to help them live longer and do better. I mean, for example, we've made great strides in the treatment of patients with heart failure, but we certainly could do better things, and similarly in arrhythmia. But the biggest challenge as for cardiologists, as I said, is the same as it is for all physicians, and that is that as I said in the book recently published, the healthcare system here is not working. It's not working for patients. It's not working for doctors or practitioners. It's a mess. And I would say that the biggest challenge I have had as a clinician is trying to navigate my way and my patient's way through this system so that they can get the best care. And it's very, very difficult.
All right, and I can understand it wholeheartedly. Because even in my situation, obviously we can speak about my situation because it's me. I even noticed like, and I'm 40 years old. It's a difference in patient care or preventative care from 20 years ago till now. And the crazy thing I'll say about my journey, you may agree or disagree. Like with mine, it was never an issue this time about the insurance or anything. It was actually how everything had to be written up a certain way for procedures to take place. I mean, anything that needed to be done right then and there was taken care of for me. But I noticed like other patients that had other insurances, that were around that I was talking to, like in between transport places, like getting some type of authorization to have something done is a very hard deal to deal with certain patients because certain insurances are not going to cover all of this, and then the certain measures to actually get to that type of care, like you're saying, if it's not streamlined a certain way, someone misses out. And that's one thing I will say in the healthcare I wish that we could fix. And that's saying in a broad way, because me and you could go more in detail, but you got what I'm saying in the fine
Mhm.
lines right there. Now, with your patient and with publications that you write, you've written many publications. Could you tell us about your latest real fast?
Um, the one- the latest, the very latest that just came off the press, American Journal of Medicine commentary about what we're talking about, which is the healthcare system and how patients and practitioners are having a very difficult time trying to figure out how to get best care. But that commentary was just published in the American Journal of Medicine about 5 days ago.
Oh, whoa. Okay, okay. Well, then let me ask you this. As far as a specialty, because you're a cardiologist, do you think sometimes from the PCP, and that's a primary care physician, like from them getting the patient to you, is it a hassle between there?
It can be, but what you said earlier is spot on, which is it really depends on your insurance. We have a patchwork of insurance coverage in this country, as you well know. I mean, some people have better insurance than others. Some people have no insurance, and unfortunately, it's an increasing number of people who don't have Think about that. Walking around without medical insurance. Think about what you would have happened to you if you did not have medical insurance when all this came down on your head. It's
I could be
astounding.
dead.
Yeah, yeah, it you hit it right on the head. We're talking about life and death. Okay, we're talking about people living versus dying. This is not a game we're playing. This isn't gambling online. I mean, this isn't some goofy stuff. This is literally life and death for people. And unfortunately, a progressively larger number of people either don't have insurance at all, or they're underinsured. That is, they don't have enough coverage. They have a gigantic deductible, so that they have to pay $5,000, $10,000 out of pocket before their insurance kicks in. Or as you said, one of the other problems is that they have to go through some kind of an arcane pre-authorization for just about anything that they need when they really need it quickly. By the way, I was really struck by the fact that you said it took 2 weeks to read an ultrasound of your heart. Um,
Yeah, well, what happened with mine, to go into better detail, the cardiologist that read it improperly.
oh,
And my physician looked at it and sent it to another cardiologist. And if that hadn't happened, because the other cardiologist said the first one said I was fine. The second one, my doctor looked at it and said, "Hey, this is not right," even though she's not a cardiologist. And she sent it to another one. They read it, and then that's when I was told, to come back in. And that was a fault of probably too many, cardiograms to look at a time. And I get that because it's a very high output job doing that. But uh, I don't know. I kind of felt like I slipped through the cracks if my doctor hadn't have cared that much. And I forgot exactly what the function was. Whatever the function of my heart was, the output that my heart was doing was like 26 and should be in the 60s.
right.
You're familiar, so you
Yeah,
know what
yeah,
I'm trying to say.
yeah.
Uh,
Your ejection fraction is called.
yeah,
Yeah,
that's
yeah,
exactly it.
yeah.
And then with insurance, and this is a true story. I mean, you could probably go on. I did have a little bit of waiting period because the hospital I was at was Charleston Area Medical Center in West Virginia, and I was at our cardiovascular unit, which is one of the nice ones. Because I'm on diabetic, they weren't able. They could treat me. They could have done the surgery there, but if something had happened to me as far as like life sustaining stuff, they'd have to life flight me to UVA or Cleveland Clinic or somewhere else. So what they did was I had to wait for Cleveland Clinic to get a bid open because I tried to go there, Kentucky, or University of Virginia. And Cleveland Clinic was the first one to respond back, which that took about 4 or 5 days. But for them to accept my insurance and everything, take which out of state, whatever, they did everything in a roundabout way. So I did kind of spend a little bit of longer time in the hospital than I thought I should have. But I got to Cleveland Clinic, and once I got there, everything got rolling. And there, and I had never heard of this. Like someone got stopped because they needed an MRI, and their insurance wouldn't approve it.
Mhm.
And I'm like, whoa, because my insurance never stopped anything. They just needed, obviously I have to wait for that bid. But outside of that, I got continued care throughout. And to know that, like that one person had to wait for prior approval to get an MRI.
Yeah, right.
I'm
Yeah,
like, whoa.
yeah. What you're pointing out is exactly what's again in my book, but it's people don't get the same level of care because they don't have either their insurances, they don't have insurance, or they don't have good insurance, or their insurance companies that they happen to be dealing with are very difficult and have a high pre-authorization rate and a high denial rate. So it's a this makes obviously it makes trying to take care of patients exponentially more difficult for practitioners. It's one of the reasons why practitioners burn out. I mean, they spend so much time trying to navigate through this very, very difficult system that it takes so much energy and so much psychic energy that they just can't sustain it. And a lot of people kind of leave the profession. It's very sad. But as I said, you were in a fortunate situation of being able to get what you needed when you needed it, and that's why you had a good outcome.
Yeah, and I'm thankful for that. And like I said, like you got me thinking more about it because it seemed like every time I would get transported to somewhere else to like get some kind of scan done, you meet these people that have waited. And I just thought to myself, like, man, in my line of work, I'm a 1099 worker. So, I pay for my insurance out of pocket. And I'm just like, well, everybody pays out of pocket, but you get what I mean. Like, and I'm just like, if if I didn't pay attention to the things that I learned in high school, because that's the last time that we really talked about health insurance was like
Mhm.
actually ninth or 10th grade PE class, like going into the health class, they talked about the fundamentals. And I wish that in high school, I know I'm going off the deep end. I wish like in high school they did a more in-depth level of teaching what type of insurance you need, just like they should go back and do economics. Like healthcare wise, you should know that, hey, this insurance should be like this for you or that, and not treat health insurance like it's car insurance. They teach you about a deductible, but they don't tell you how it's going to hurt you in the end or how you're going to meet that deductible. And that's something I think the education, on that part needs to be taken care of. The government should at least try to do something in the school system, before they get out or at least eighth grade. Because half the people, I know it sounds really ignorant what I'm about to say, but I am going to say it. I know people that are my age and your age that are health insurance illiterate.
Mhm.
And
Well, JR, that I think there's a deeper problem here, and that is that everybody has difficulty understanding the healthcare system and reimbursement. For example, if you canvass Medicare patients, and remember, these are people who are in their 70s and 80s. Some of them don't have the same mental capacity that they had when they were younger. Almost every Medicare patient will tell you that they've had some difficulty with navigating the system. Remember, Medicare doesn't cover everything. It covers 80% of the cost of most of this of medical services. So you have to have some other kind of insurance or Medigap or Advantage or something else to cover the rest of it. And it can be quite difficult to figure out how to do that. So I'm going to go back something and say something a lot more basic than where you just ended up. And that is to solve this problem, we need to provide medical care for everybody in this country. And we just need to get over this. We need to become like all of the other developed countries in the world where medical care is provided for its citizens. And we just haven't done that in this country, despite the fact, JR, that we spend $5 trillion a year on medical
my
care in the United
Lord.
States. $5 trillion, but we don't provide medical care for everybody. And it just doesn't make any sense. And I'm not talking about, you know, the best levels of care. I'm talking about basic stuff. Being able to go see a primary care doctor, being able to go to the emergency room when you're sick, being able to get your medications at a reasonable cost, not having to make a decision between whether you're going to eat or take your pills. I mean, it's the stuff that's going on here in the basic economy of medical care is outrageous. We've abandoned our responsibility. So I know that people get all hung up on this socialized medicine nonsense and Medicare for all that. People have to get over this and understand that the only way that people are going to get the care that they need is if they can afford it. And the only way to make them afford it is by giving it to them as a citizen of the United States.
And I could see that sort of like how Canada does to a degree,
Yeah.
and
I
we
mean,
can
it
make it
doesn't have to
work.
be, yeah, it's not just Canada. I mean, every European country,
Yeah.
the United Kingdom. I mean, we're not talking about backwater countries. We're talking about developed countries that have figured this out. Now, everybody talks about, you have to make some sacrifices, and you do. There may be a little bit of a longer waiting period, for example, to get an operation or something if in a socialized system, but it's nothing. I mean, we have that problem now here. Try Go try to make an appointment with an endocrinologist or a neurologist in this country. You're talking about months and months before you can get in
Yes.
to see somebody, right?
Right.
It's not any better here than it is everywhere else. We just pay a lot more for service that is subpar. And we just have to stop. I mean, we have to stop doing this. And the only way to do that, JR, is that we have to get our legislators moving in that direction. We need to get over this bipartisan. We have to get over this partisan politics that has divided our country. They need to get together and come to some real solutions.
They do. And I agree with you on that. Because, like you said, just with the little scare that I had and just knowing everything I seen in that 20 days that I was in a hospital and moving around, and you hear the chatter that goes on, and just seeing how like the level of care from a hospital in West Virginia to a hospital in Cleveland, Ohio, just seeing the difference in everything and how things are done, how patients are treated, and how expressive the doctors are about the care. Because obviously, being at Cleveland Clinic, that's research. We know that they're gonna, that's a teaching place, and
Mhm.
even at the hospital in West Virginia, that's a teaching hospital too. And you have doctors and every people that are eager. One thing that I heard you talk about is the burnout of the physicians. I could see that happening, knowing that somewhere along the line, all the hard work that you all do, someone like a patient getting lost in the shuffle of all of this weird healthcare setup that we have. So I do thank you for that. Now, if you could for me real quick, I need you to do this for any up and coming physician or resident out there. What would be the best advice you would give them to maneuver in these waters? What would you tell them? How would you encourage them and motivate them to not burn out and to try to find a way to help their patients beyond what's in front of them?
Well, everybody goes to medical school. When we interview medical school applicants, for example, the first thing they want to tell you is that they're going into medicine because they really want to help people. And it's real. It's true. They do. That's one of the big motivations. I don't think that the vast majority of people who go into medicine are not going into it for the money or for the prestige or any other junk. They have a legitimate caring for people. The problem is that they go through a medical education process that dehumanizes the situation, and they get taught things that are not as important to the patient as they are to the system. For example, I don't know if you if you watch The Pit or you watch
Yes, I
ER
do.
or one of these shows, yeah. So if you watch what the emphasis is for the trainees is learning how to do procedures. They really want to do spinal taps and thoracenteses and all kinds of things. And there's a real reason for that. You do need to learn those procedures, but the thing that is the most important to the patient is sitting down and talking to them and answering their questions, laying hands on, right, doing a good physical examination and making sure that they get all their questions answered and that they understand exactly what's happening. I hope that people who are going to go into cardiology or any area of medicine maintain the idea that the thing that they need to do best not a procedure, but is actual sitting down and taking care of patients. And I think if we all can refocus on that, I think we would probably be better off. One of the reasons we've run into this problem, JR, is that not only aren't we teaching that in medical schools, but unfortunately, we're also putting practitioners under incredible amounts of pressure. So, one of the things that I think is the most evil about modern medicine and the thing to tell people who are going to be training, I call it the 10-minute visit. So you go to see your doctor and they have 10 minutes with you, maybe 15 if you're lucky. Now think about how absurd it is that you're going to try to deal with all of your medical problems, all of your medications, all of your questions, your follow-up, and then write some kind of a note of what happened during the visit, all in 15 minutes. It's impossible. You can't do it. And the reason why people have those very short visits is because they stack 20, 30 patients into a day for a doctor when they really don't have time to do anything other than walk into the room and try to get things done as quickly as possible and get out. Um, we need to change the fundamental way that we pay doctors more for time with the patient, less for procedures, and also just change the whole orientation.
Okay. And I agree with that. I noticed that when I got to Cleveland Clinic and they had students that were coming in, I noticed a bedside manner. And the interesting thing was it was a European doctor, a doctor from India, then there was a American doctor and a doctor from Africa. And I noticed that the American doctor that was there made eye contact with me when they were telling me everything. The other ones didn't. So the second day that they came in, I noticed that that doctor must have talked to them, and they all made eye contact with me after that. And then when they all came in on separate occasions, they warmed up more. And I talked to each doctor and I said, "Your bedside manner has improved." I said, "I'm really impressed with the information you're bringing me." And obviously, I quizzed them on this and that and whatever else was going on with me so I could learn more from them. And I liked how they were being informative. But like you said, that bedside manner is something that it's hard to develop. And for them to develop it that quick, I was really astounded by that. So I get where you come from there. Now, Peter, before we jump off of here, I need you to do me something, one more big, huge favor. I need you to leave the world with your lasting impression. Now, your impression, this has got to be something fairly big because this show goes out to about 30,000 people, which we don't care about the number of people, but 30,000 people, 100 people are going to listen to this and you're going to save somebody's life through your voice today and through video. So, the floor is yours. You're at Carnegie Hall, since that's Pittsburgh area for you. You're out there and you're giving your life statement. The floor is yours.
Well, I am eternally grateful for the opportunity to have taken care of thousands of people over the course of my career, and as we discussed earlier, also have the opportunity to develop new therapies for literally millions of people around the world. I've been extremely privileged. And as I have come to close to the end of my career, one of the things that occurred to me was that I had not, although I remain very positive about medicine, I have not communicated to the public how important it is that we maintain a high quality of care for all of the people in this country and around the world. Um, when you get sick, and you've had this experience very recently, when you get sick, there's nothing else on your mind, right? I mean, the whole world revolves around this illness, and you can't do anything else effectively. I mean, you can't work, you can't have fun, you can't really relate to other people the way you want to. You have this tremendous weight on your shoulders. The ability to lift that off of somebody's shoulders, to make them well, to put you back in front of the microphone, to make sure that the quality of your life is good and that you're going to live a longer life. There's nothing else in the world that's better than that. I mean, there's no other thing in the world that you can do. There's no other job in the world that's better. We want to preserve that. We don't want that to go away. We don't want to turn doctors into automatons and clerks, people on shifts, coming in, working 8 hours and going home and not really thinking about what's happening. We want to develop physicians that are still caring and thoughtful and insightful and effective in doing the things that are important to make patients better, both from the scientific point of view as well as from the psychological and emotional point of view. Uh, the book that I wrote, The Failure to Treat, was because I needed to speak out and make sure that everybody understood that we need to stay on that mission to make people feel better and do better, and hopefully that's been accomplished to some extent.
All right, and where can they get this book? Where can they find this book? We'll do a little shameless plug.
It's okay. It's Peter Kowey, Peterkowey, author.com is my website. And you can get the book. It's called Failure to Treat on Amazon. But if you want to just take a look at it and see what it's about and see some of the interviews that I've done, including those with you, they are available on the website. I would encourage you to go there. And the website also gives you some feeling for what we're trying to accomplish. Again, it's not the book that's the important thing here. It's the message that the book is bringing.
All right, and I thank you so much for that. And this has been a really enlightening episode. And obviously, with the narrative of the heart problems that I've had, this has worked out very well for me. And I would like to invite you to come back later on. We will have to do a follow-up show just because there's so much we can cover and so
Yeah.
much deeper levels that we can go to into the healthcare system. And we can get more, we can ask more questions, get more answers out of you. And I want to thank the audience. And one thing I want the audience to do for me real quick is when you're done listening to this, it's a part of the podcast that we call the after podcast. That's the show notes. Inside these show notes, you'll be able to find where you can meet Dr. Peter Kowey, and you will be able to find him on the internet. Every link and everything will be in the show notes, and it'll be across every podcatcher and YouTube when this video is available within the next 2 weeks. And you'll be able to meet and greet him and get into his ecosystem and just talk to him and learn more about the man, the myth, the legend. And once you do that, you will embark on something that I'll be embarking on myself later on, learning more about what's wrong with the healthcare system.